Good afternoon, and thanks to the organizers for inviting me to this really terrific meeting. I didn't know I had 30 minutes, so I'm going to talk really fast like this. No, just kidding. But I didn't. So let's see. So what I plan to talk about here was syphilis and HIV with a focus on neurosyphilis. So I'll start by talking about syphilis epidemiology with using the US as an example. And then we'll run through a brief overview of uncomplicated or non-neurologic syphilis. And then we'll tune into neurosyphilis, focusing on HIV. And then I have 3 patient cases to present to you for you to vote. So beginning with US syphilis epidemiology, this is a graph of the number of cases of primary and secondary syphilis beginning in 2000 going through 2016, which is the last year for which we have data. And you can see a progressive increase in the number of cases, but when we got to about 2012, things really took an uptake, and we've had about a doubling in the number of cases just in those 4 years. In the US in 2016, most primary and secondary syphilis cases were men who have sex with men, and 47% were HIV infected. Maybe I can use the mouse this way. Okay, so this is men who have sex with women. You can see that 11% were HIV infected, 4% of women with syphilis were HIV infected, and here's the MSM, 47%. But the interesting thing about this is the number of cases, if you look at the CDC data of MSM who are HIV infected, is actually going down. And locally in our community, the number of cases of MSM with HIV who have syphilis has gone way down. So it's more turning toward an HIV negative epidemic in MSM. The increase in syphilis that we've seen in our community parallels what's happened nationally, and that's what this graph on the left is showing you. Number of cases of early syphilis, so primary, secondary, and early latent, in Seattle-King County where I live, beginning in 1992 and going through November of this year. And you can see just a progressive increase. In fact, since I made this slide, I just got the data, and there are about 100 more cases to add to this last year. Because of this increase in syphilis in my community, I was able to do a large study of CSF, cerebrospinal fluid abnormalities in syphilis, and I'll show you some of the data from that study. This study went on from 1996 through 2014, was sponsored by our government. And the entry criteria were really simple. The patient had syphilis and their provider thought they needed a lumbar puncture. Patients underwent a standardized history and exam, a lumbar puncture, and a blood draw. And if they were treated for neurosyphilis, they came back at 3, 6, and 12 months. Our enrollment is shown in the orange bars. And I just showed that to you to point out that the light orange bars are people who came back with syphilis during our study. We had about 130 patients who came back with between 1 and 5 more episodes of syphilis during the course of what we did. And the characteristics of our 964 unique participants are shown in the table. Most MSM, about 3/4 HIV infected, 70% with early syphilis, and about 14% had a reactive CSF VDRL, which would have diagnosed neurosyphilis. So an overview of uncomplicated syphilis, Treponema pallidum, the bacterium that causes syphilis, is incredibly infectious. The risk of developing syphilis after a single sexual exposure averages around 30%, which is much higher than HIV. And the risk is highest in contact to early syphilis, so primary, secondary, or early latent. This flow diagram just lays out for you what you already know, that syphilis is a disease that occurs in stages separated by periods of latency. Primary syphilis, a single, usually well-demarcated, painless ulcer or chancre at the site of inoculation. With or without therapy, it'll go away. It'll go away faster if you treat. Without therapy, patients will go on to develop secondary syphilis, the vast majority, characterized by a maculopapular rash that can involve the palms and the soles, condyloma lata, which are flat wart-like lesions in warm areas, or mucus patches shown in the picture of the tongue below. Oops, I was afraid that was going to happen. So let's do this. Okay, previous. And I'm going to go back and do it again. Ugh. Can somebody help me? Can somebody help me? Go back on these. If I have to use the mouse to point, keep going back, 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 the other way, other way, other way. Okay, thank you. So back to there. It's the orange, that's it. Okay, now forward, please. Keep going. Keep going. More, please. Again. 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 Okay, thank you. Stop there. I'm just not going to touch anything. Okay, so again, secondary syphilis will go away without therapy. It'll go away faster if you treat, and patients enter latency when they have no clinical manifestations, but their serologic tests are positive. And latency can be early or late. Early in the US is in the first year of infection. Late is after a year. 70% of patients with syphilis who are never treated maintain their latency lifetime, but about 30% will exit from latency with tertiary syphilis, gamma, a focally destructive lesion of the bones, cartilage, internal organs, or cardiovascular disease, ascending aortitis, coronary vasculitis, and sometimes myocarditis. The important things to note from this slide are, one, that neurosyphilis isn't on it. So neurosyphilis can occur at any time in the course of infection, and we'll come to that. And the other is this area of early latency. So it just means the patient has positive serology, not been, and has no clinical manifestations. And we say it happens after secondary syphilis, but really a person could be latent before primary or latent before secondary. So it's pretty artificial. We diagnose uncomplicated syphilis based on the clinical findings we just talked about. You can identify treponema pallidum in lesion exudate by dark field, or you can use PCR or other nucleic amplification tests on any biologic fluid or tissue. But we really rely on serologic tests to make the diagnosis of syphilis, which is a problem. And there are non-treponemal serologic tests. The VDRL, the RPR, and the TRUST are the most common ones. They measure IgG and IgM to cardiolipin cholesterol lecithin antigen. They can be used qualitatively, yes, no, reactive, non-reactive, positive, negative, or they can be used quantitatively, typically in multiples of single dilutions, a twofold titer. So 1 to 2, 1 to 4, 1 to 8, et cetera. The important thing about titer is that titer can be used to define response to therapy, and a 4-fold decline is considered to be success. So going from 1 to 8 to 1 to 2, for example, 1 to 32 to 1 to 8. So divide by 4. That's the definition of a successful treatment. The other serologic tests we have are treponemal serologic tests, like the FTA-ABS, the TPPA, I think you have the TPHA, and then a bunch of EIAs and chemiluminescent assays. They measure IgG and IgM to treponemal antigens, and they're used mostly qualitatively, so positive or negative, and they generally remain reactive for life. Syphilis treatment is based on stage. The CDC recommends benzathine penicillin, a single dose for early syphilis, 3 weekly doses for late latent syphilis or syphilis of unknown duration. Doxycycline is an option in people who are penicillin allergic. And the thing to remember about these regimens is they don't treat neurosyphilis. In particularly, you can isolate T. pallidum or T. pallidum DNA from spinal fluid after 3 or 4 weekly doses of benzathine. So we're going to move now to neurosyphilis, and this is my flow diagram to show you the clinical course of neurosyphilis. So besides being very infectious, treponema pallidum is very neuroinvasive, and you can identify the organism in the spinal fluid of a person with primary syphilis. But unlike other bacteria that enter the CSF, it doesn't necessarily persist. The normal host can either directly clear the organism or develop a meningitis and clear. Those people who can't clear have persistent meningitis, which we also call asymptomatic neurosyphilis. And I would point to that box there, but if I do, the computer will be completely screwed up. So you're just going to have to look at it. So persistent meningitis, asymptomatic neurosyphilis is something that happens early, and these are the people who are at risk for symptomatic disease. And symptomatic disease can be early or late, and the early forms can occur from weeks to months to the first few years of infection, And they include symptomatic meningitis, including a gumma, which is a focal area of meningeal inflammation. You can have hearing loss, vision loss. A little bit later, patients can develop meningitis and stroke. And then years down the road, the late manifestations, rapidly progressive dementing illness with psychiatric symptoms, general paresis, or tabes dorsalis, spinal cord disorder. We really don't see these late forms very much. We really see the early forms. Neurosyphilis is diagnosed based on clinical findings. Neuroimaging can sometimes be helpful, but we really depend on spinal fluid. You should see an elevated white cell count, typically above 10, mononuclear, elevated protein. CSF VDRL is specific, so if it's positive, it rules in the disease, but negative doesn't rule it out. CSF FTA ABS is sensitive. Negative test rules it out, particularly in asymptomatic neurosyphilis, but a positive test doesn't rule it in. I think I'm just going to skip all this stuff in the interest of time and move on to the issue of HIV. So is symptomatic neurosyphilis more common in HIV? This has been discussed, and there are no population-based data, and that's a real lack in the field. But Melanie Taylor did a study from Los Angeles a few years ago and identified 109 cases of neurosyphilis in the LA County Health Department. She estimated the rate of symptomatic neurosyphilis in patients with early syphilis and who had HIV at about 2%. In the similar HIV-negative people, it was about 0.6%. So about threefold more cases of early neurosyphilis in HIV-infected people. So if that's true, why might it be true? And it takes us to the issue of neurorelapse, which is something that was identified in the pre-antibiotic era, but was brought up again by Dan Musher many years ago. He identified 42 cases of neurosyphilis in HIV. 16 had received benzathine, normal, one dose of IM benzathine penicillin, and about a third of those developed neurosyphilis within 6 months. So sort of a rapid progression from early syphilis to neurosyphilis. And this was described in the pre-antibiotic era in patients who got treated with inadequate courses of therapy. Now, that therapy wasn't antibiotics, but the thought was that inadequate courses did not treat the CNS or the CSF, so the patient had organisms in that protected site. They downregulated their immune response because peripherally they were cured, and the combination of those two things put them at risk for neurosyphilis. And Dan made the same analogy to the HIV-infected person. We treat with benzathine, it doesn't get into CSF, and the patient has HIV and is immunocompromised. I'm going to skip that. So the idea is that instead of the natural history being what I showed you before, here, it's like this, that clearance is impaired in the HIV-infected patient, so that they experience CNS invasion and are more likely to go on to persistent meningitis, which puts them at risk for symptomatic neurosyphilis. And what data do we have to support that? These data are taken from my study, looking at 577 HIV-infected individuals who had symptomatic neurosyphilis or asymptomatic neurosyphilis or neither. And we strictly defined neurosyphilis based on both the clinical symptoms or lack of them, and CSF abnormalities had to have more than 20 white cells or reactive CSF VDRL, so very rigorously defined. What we found was that the risk of asymptomatic and symptomatic neurosyphilis in HIV was higher in those who did not receive antiretrovirals. So patients who are not taking antiretrovirals were about twice as likely to have asymptomatic neurosyphilis, about fourfold as likely to have symptomatic neurosyphilis, compared to their counterparts who were taking antiretrovirals, even taking into account other factors that influenced risk. I'm going to skip this, and we'll go to the 3 patients. So get out your phones, please. I never did get this to work because I don't have internet access in here, so I'm depending on you guys. So that my first patient is a 58-year-old HIV-infected man who has sex with men. He's on antiretrovirals, he has a high CD4, and he's undetectable. He presented to his provider with a 1-month history of headaches, and his MR showed a left temporal lobe mass, and I'll show it to you. He had a spinal fluid examination, 4 white cells, normal, protein mildly elevated, and they didn't think about syphilis, and they resected the mass. So here is his MR. So the top panel is the flare, and the white arrow is pointing to this area of edema in his left temporal lobe. And then the bottom two are sagittal T1s with contrast, and the yellow area shows you sort of an area of meningeal enhancement that's dipping into the sulcus, and it has kind of a nodular appearance. Okay, so what's the most likely diagnosis? Here are your choices: meningioma, metastatic tumor, syphilitic meningitis, or a gamma. So I'm going to push vote, and you'll have a chance to vote. Okay, so it looks like most people thought it was full D, cerebral gamma, and that I think is right. The people who voted for syphilitic meningitis are also right, because gamma is a form of meningitis. So here's what happened. I actually was called about this patient, and they sent me the MR, and I asked if they had tested for syphilis, and they went ahead and did. And his serum RPR was reactive, his TPPA was reactive, and I don't remember the titer. But we actually got the tissue, and we amplified it for T pallidum, and that's what the gel's showing you. The patient is column 1, and you can see faintly his band. The second column is the negative control, and the third column is the positive control. So you can see that we amplified T pallidum from his brain biopsy, or his brain resection, and he had a gamma, and he was treated with penicillin. Unfortunately, because they didn't think of this as the diagnosis, he ended up having a brain surgery and also ended up having trigeminal neuralgia as a consequence of his resection. So as we pointed out, a gamma is a form of meningeal syphilis. So those of you who voted for meningeal syphilis or gamma, you're both right. It's just a focal area of inflammation. People with meningeal neurosyphilis have neurologic abnormalities, including headache, stiff neck, nausea, and vomiting. My patient had headache. They can have cranial nerve abnormalities, most common in the first year after infection, even in the pre-antibiotic era, and treatment leads to clinical improvement. This is another example of a gamma of a patient I saw who had secondary syphilis and presented with a seizure. So the image on the left is a flare, and you can see a lot of edema in his posterior left frontal lobe. And then the image on the right is a coronal with contrast. And again, you see this enhancement that follows the sulci and dips in. That's really characteristic of a gamma. If you see that, you should say so. And the other thing to think about would be a meningioma, because they can look very similar. Okay, so didn't fool any of you on that one. Let's do patient 2. So this is a 46-year-old HIV-infected man who's not on antiretrovirals, and he presents with 2 months of headache and photophobia. He has a macular rash over his torso. His providers astutely thought that he had syphilis, and he did. His serum RPR was 1 to 1,024. That's the titer. TPPA reactive. Inflammatory CSF, 187 white cells, protein of 125, and CSF VDRL titer very high at 1 to 32. He started IV penicillin and antiretrovirals on the same day. And 5 days later, he developed confusion and left arm and leg weakness. So here are some images from this patient. So the first 2 on the left are diffusion-weighted images when he first presented, and the radiologist has put little arrows on these areas of restricted diffusion. And then the image on the right was actually 5 days later. He developed more of these abnormalities on diffusion-weighted imaging. This is his CTA of his head. So this is not an MR, it's a CT, and the radiologist has put a little mark there to point out to you that he has some narrowing of his right middle cerebral artery. So again, a question for you. What's the most likely diagnosis? Immune reconstitution syndrome, stroke, immune reconstitution syndrome and stroke, or meningovascular syphilis? I'll hit vote, and you can go ahead and use your phones. Okay, so let's see. Some people thought immune reconstitution syndrome, So equal numbers thought stroke or immune reconstitution and stroke. And most people who voted thought meningovascular syphilis. So there's not a correct answer to this. I don't actually know. I mean, I think he had meningovascular neurosyphilis. He had meningitis and stroke. But the issue of iris, I think, is really interesting because iris is very uncommonly reported in syphilis. But really, he developed the stroke and then more strokes after he got started on antiretrovirals. So I think it's an interesting hypothesis, and I wouldn't grade you as wrong for having said that he had iris. So meningovascular neurosyphilis, CSF abnormalities, and stroke can involve the brain or spinal cord. Before we had penicillin or HIV, the peak time that people got meningovascular syphilis was 7 years after infection, but I think it's actually much earlier than that. My experience has been almost exclusively patients with secondary syphilis. And treatment leads to clinical improvement. It will help with the meningitis, but it won't help with the stroke, so residual deficits are common. So that was good. You guys did well. So here's my last patient, a 38-year-old HIV-infected man who has sex with men. And he has a 1.5-year history of cognitive and personality changes. When I saw him in clinic, he was very giddy, laughing sort of inappropriately. He had trouble following instructions, and he scored a 24 out of 30 on the mini mental state. His serum RPR was 1 to 128, and his TPPA was reactive, and his white cells in his CSF were pretty elevated, not as high as my previous patient, but 78, protein of 120, and a really high CSF VDRL titer at 1 to 128. So here is imaging not from him, but from a patient I think had the same thing. This was a case that was presented to me at Rush University. So on your left should be the diffusion-weighted study, and you can see the increased signal in the left medial temporal lobe. And then on the right is a flare where you can also see it, although I think it's easier to appreciate on the diffusion-weighted study. Okay, so what's the most likely diagnosis in this patient? Syphilitic meningitis, meningovascular syphilis, general paresis, or tabes dorsalis. We'll go ahead and vote. Okay, so it looks like most people thought it was syphilitic meningitis, and then the rest were sort of split between meningovascular, general paresis, and tabes. Okay. So I think this is a case of general paresis, although some people would argue that it could be meningovascular, but the imaging abnormalities didn't really fit a vascular distribution. So general paresis is a dementing illness characterized by psychiatric abnormalities. Forgetfulness, personality changes, can develop dementia and other psychiatric symptoms. The onset is 10 to 20 years after infection, and treatment leads to clinical improvement, although residual deficits are common. This is obviously not my patient. It's a pathologic specimen that Dr. Mark Sumi gave me many years ago. But I put it here to show you that you can see in the front of the brain image that the meninges are cloudy. So all neurosyphilis begins in the CSF and the meninges. And then as time progresses, it enters the tissue and you get parenchymal disease. So the reason I think he had general paresis is that he had dementia, he had very abnormal spinal fluid, and I knew in talking to him that he had been with his current partner for 11 years, and his current partner was serologically negative for syphilis. So I think he was infected for at least 11 years and probably more. This isn't tabes. Tabes is a spinal cord disorder characterized by pain, dysuria, ataxia. This is where the Argyll-Robert pupils are seen, lack of reflexes, loss of proprioception. It's the kind of neurosyphilis that has the longest incubation period, and it can often have normal spinal fluid and doesn't really respond well to treatment. And this is another pathologic examination from Dr. Sumi. So I'll end there, and then should I take questions now or later?
Yeah.
Okay, now. Okay, thanks very much. Special thanks to those who voted.